my apologies that Elizabeth can't be here today. She's our director. If any of you know her, she's an extremely engaging speaker, but I've done this talk in the past and feel very comfortable doing it, so thank you for being flexible enough to host me. I like walking around too, and I would walk around the way Dr. West did, but anytime I get a chance to be a little bit taller, I don't give it up easily, so you have to drag me off of the stage, so I'm not going down there. So I do work for the Office of Children's Mental Health. We are a state-level agency, and our charge is very broad. We are supposed to look across schools, social services, corrections, child welfare, all of these different agencies, and figure out how's it going. And I'm the one research analyst. So as you can imagine, just trying to do this in La Crosse, we're trying to do it statewide, there's a lot to dig into. And it's a very exciting time to be doing this work because there's a lot of momentum around the state, just like you have here. And there are a lot of entrenched problems that we're finding that are very much in line with what you have already been addressing. So that's what I'm going to kind of highlight a little bit today. Some of what we're seeing around the state, a little bit of how La Crosse fits in, and mostly how we try to think about it in a holistic way, and how we kind of try to get people to think about children's social and emotional well-being. Because as you all know, we're not just talking about a child, a single student, we're talking about somebody who's embedded in a family, in a neighborhood, in a community, in a school system. And I know you know this because that's why you're all coming together and doing the work that you're doing. So we are the Office of Children's Mental Health, but we like to think of ourselves as looking much more broadly at brain health, at social emotional development. And we like to start, even though none of us are biological scientists, we're following the wave of people right now who are starting to go back to brain science and saying, what can this tell us that can inform our practice? What can we learn from what neuroscience is trying to understand now and apply it in schools, and apply it in neighborhoods, and apply it in community policing and housing? So I know this community has done a lot with trauma-informed care. I know you have an ACEs workshop this afternoon. How many of you have seen this slide or similar slide before? Quite a few, okay, most people. So you pretty much know what the story is here. So this is the story of two brains. And what's the difference between these two brains? Anybody? Well, you can't read the labels, just tell me. Yeah, right. So one is the healthy brain, and one is the brain of a person who has been neglected. We find similar findings when children are abused, and thanks to the work of people like Seth Pollack at the Wiseman Center at the University of Wisconsin and his colleagues, we also know that we have similar findings when children are not abused, not neglected, have good parents, but grow up in poverty. So this is the brain that's experienced severe disruption, scarcity, all of these kind of things. And so what this is showing us, as many of you already know, is these areas up here, wherever my clicker is, in the circles. This is the stuff that you who work in schools are really very much concerned with, right? Prefrontal cortex, this higher functioning area right here. In the brain that hasn't been neglected or abused or exposed over time to generational or extreme poverty, we have a lot of activity up here. And what that activity translates into is the ability to control impulses, to regulate emotions, to plan for the future, to study for a math test, to think, I need to get to college and this is the way I'm going to go through it, right? Those kind of things. Down low, we have our reptilian brain, right? The limbic system, which is in contrast to that. And so that's the part of us that saves our lives when we need it, that sends us into that response, but it's that fight, flight, freeze. I feel like there's another one. Is there another one? Fight, flight, freeze, eat, something like that, I don't know. So this part is much more active in somebody who has always had to be in survival mode, right? And somebody who's often triggered, because it has to be. That is an adaptive response. So when Dr. West is talking about that childhood scene where he's in his neighborhood and there's gunshots, you better have a limbic system that's well-trained to respond quickly. You drop. You don't sit there and ask questions. You don't sit there like I would and be like, what's happening? What happened? Is everybody okay? You don't do that because it's not adaptive in that situation. But that same response is not very adaptive in the classroom, right? When you have somebody who's always on alert looking for, where's the danger? Where's the opportunity to get food if I'm hungry and I know that I need to take that opportunity as quickly as possible? So both of these parts of our brain are vital, but they do very different things. So think about this. This neglected brain, it looks like it almost has holes up here. There are holes in this net. There is a huge gap up here, and this part is very active. So think about the child who is sent to the dean of students' office or the principal's office or the teacher, and we're saying to this young woman or young man, whose brain might look like this, make good choices. Make good choices, right? You might as well be saying to me, make a jump shot. Because I can try, but I don't have that naturally. So you better help me understand, how do I make those good choices? Okay, you want me to have emotional regulation. You want me to have skills in place that I can develop. I can develop those skills with Mrs. Johnson's help or with all of these other people's help. But it's going to be a lot harder for me because of these things. And so all of the disruptive, annoying, aggressive, disengaged kind of behaviors that your staff are seeing, or you as a frontline staff perhaps are seeing, are perhaps, and you know this already, I know you do, clues to scratch the surface. Okay, all right, so what is really going on here? And if we can start to switch that, where we're not seeing it necessarily as, this person is disrespectful, I want you out, but this person really can't calm down. What is going on here? Does this person's brain perhaps look like this brain? And a lot can be done with these brains because the brain remains plastic for a lot of our lives, but it's a heavy lift. A lot needs to be done in those situations. So if we can walk around as educators, as policy folks, as service providers with this image in our brains, I think it can help to shift the way that we train our staff, the way that we engage with our personnel, the way we engage with our coworkers, right? Because people reach adulthood like this too, and figuring out, well, when am I triggered? And why am I responding to this child in this way? Oh, she's talking to me the way that I talk to my mom. And that really ticks me off. And so now I'm losing this ability up here. So I have found this very helpful, both in speaking to groups and, as a parent, my kids are young, so they're still developing this. So just the developmental psychology kind of aspect is really helpful. So we were looking at that damaged brain, and you already have been exposed to the research on the ACEs, the adverse childhood experiences. So a lot of what I'm going to talk today is ACE-related data from Wisconsin. So the adverse childhood experiences data, as you know, shows that things like abuse, neglect, divorce, loss of a parent, what else am I missing here? Substance abuse, mental health issues in the home, have severe and lasting effects on a person throughout their lifetime. Can people overcome it? Of course they can overcome it. But again, it's a harder lift. It's much more difficult. So this is the population attributable risk of various health outcomes attributed to ACEs. So what this ink blot, we call this the ink blot, what this ink blot shows is if you got rid of people's adverse childhood experiences, if you could wave a magic wand and take away all those horrible things that happened to people in childhood, you could, statistically speaking, get rid of 42.7% of the mental health medical treatment or pharmacotherapy. You could get rid of 55.7% of the cases of anxiety. You could get rid of a large proportion of HIV and high-risk sexual activity, heavy drinking, cardiovascular disease, cancer, separation, divorce, life dissatisfaction, mental health conditions, hopelessness. So what we're saying is this crosses domains. So, the ACEs study, I think probably many of you know, originated not from studying things like disruptive behavior or depression or anxiety or any of that. It was an obesity study. And they were trying to figure out why aren't people losing weight. And they realized when they started asking about these adverse childhood experiences, people started losing weight. These things that seem completely unrelated because we're really much more holistic, right, than we tend to see ourselves. So we think that ACEs are a pretty fundamental thing to understand. And so because of that, we're really interested in, yes, getting more mental health providers for those cases that manifest when kids have anxiety, when kids have ADHD. You know, so many times there's a trauma situation, there's instability going on in a child's life, and the diagnosis, correctly or incorrectly, is ADHD. Well, that's ADHD. If we start to scratch the surface, the research shows many times that's trauma and instability in a child's life that can be addressed by moving down this pyramid and figuring out what else is happening. So we want to speak not just to mental health providers, but more to people like you in this room, to look at student support services, to look at coaches and consultants who can go out into the community, to look at youth and parent specialists, and skilled child-serving workforce, which is the folks you work with, to basically get us down to having safe, stable, nurturing, and informed families to reduce the prevalence of things like ACEs. So I'm going to just show you a brief 5-minute clip. This is from the Harvard Center on the Developing Child, and they are really the ones who have put forward much of this research on ACEs in the developing brain. They're a great resource. They have little quick videos, and they have some great handouts if you want to use them. And this shows why look to adults if you want to help improve outcomes for kids. Why do we need to have safe and stable adults? You all know this, but I think it captures it quite well. Whoops, so how do I get my mouse? I'll skip it. It worked when I was testing it, but of course it's not going to work now. Okay, skip it. So what I'll say is, if you look at a video, they have several like this. Their point is, there are so many roadblocks in kids' ways. And we can have individual programs that are targeted programs to deal with children and youth, and those are important programs. But you're going to get the most bang for your buck if you have a skilled child-serving workforce. And I was really happy to hear that next year, this kind of forum is going to have more frontline staff here. Because many of you know these messages, and you know this already, and the people who, it needs to filter down from you to the frontline workforce. And so when you get the gym teacher knows about ACEs, the bus driver knows about ACEs. All of these people have that image of those brains in their head and can start to think not just about why is this kid being a punk, but okay, how can we restructure things so that disruptive behaviors are minimized, things that trigger kids are minimized, and we can start to pull out kids' strengths. That's what we're trying to work for. So that's a little bit of our perspective. I'm just going to quickly give you a few stats so you kind of can pull these out of your pocket. What do we know about children's mental health, social, emotional well-being in Wisconsin? So this is a little bit of background material. So Wisconsin does not stand out in terms of how many kids are facing mental health challenges, but it's still extremely prevalent. So up to 1 in 9 children has what's called severe emotional disturbance. In school lingo, it's more often, it kind of correlates with emotional behavioral disability, right? Emotional behavioral, what's the D? EBD. Do we not use EBD anymore? Use it in the special ed world. EBD. And 1 in 5 Wisconsin children has any mental health challenge. So you think of a typical classroom, 1 in 5 has something that's a diagnosable mental health challenge. That's a lot of kids. We know that there are certain groups that are at higher risk. So sexual minority youth, LGBT, 57%, according to the YRBS data, the survey of high school students, have experienced depressive symptoms in the last month. African Americans, nationally, black youth have about 25% higher incidence of mental health challenges than white youth. And we'll talk about how we're particularly bad about that in Wisconsin. Because being in the super minority and being in a place with extraordinary disparities, as we'll see, makes it a little bit harder. There's not a lot of community support. And those in poverty. So I talked about before, Professor Seth Pollack's work is showing that when kids start out, he looked at kids from different socioeconomic classes. He did their brain scans when they were 5 months old, when they were 2 years old, when they were 4 years old, when they were 6 years old. They all started out with the same brain mass, and then they diverged. So those kids in poverty are not born with a disadvantage in terms of their brain development, but they acquire it through the accumulated stress of scarcity and fear that is low grade over time. So kids in poverty have twice the rate of severe emotional disturbance as non-poor kids. Almost half of Wisconsin kids have any ACE, and this is the National Survey of Children's Health. So they asked parents to report on their kids. So because they were asking parents to report on their kids, they didn't ask parents which questions, about what? Did you or anybody else living with you sexually abuse your child? They did not ask that question. Did you or anybody else living with you abuse your child? They do not ask that question. So this is 46% of Wisconsin kids have experienced the other ACEs. They did ask, do you have a mental health concern? They actually did ask, do you or someone living with you have a substance abuse concern? They asked some of those questions, but not the ones pertaining to kids. So 46% said yes to those questions. And then if they had asked the questions about parental abuse and neglect, we can bump that up even higher. So 1 in 5 kids has a diagnosable mental health disorder. And then we look at almost 50% of kids are dealing with some incredible amount of adversity or trauma. And again, that doesn't make Wisconsin unusual. That's pretty on par for the nation. We know parental incarceration is an adverse childhood experience. We also know that we don't have very much good data on how prevalent it is. So I did get some information from the Department of Corrections. They asked once in 2012, they looked at all the adults who were in their system, and they said, how many dependents do you have? And at that point, they tallied them up, and there were 18,000 children who had a parent incarcerated at that point in 2012. But that's a point in time. So that National Survey of Children's Health, they asked the parents, have you or anyone you lived with been incarcerated in the first 5 years of your child's life? And 15% of that sample said yes. So that's a much higher number. So if we look at that, we have to just kind of estimate, because it was a sample and they were asking parents, they didn't ask how many kids were in the household. But if it's about 15% of, it's 50% not of the state, 15% of those on Medicaid, 50% of Badger Care. 50% of kids on Badger Care would be about 75,000 kids in Wisconsin. So that's a lot of kids who've had that kind of adverse childhood experience in our state, in early childhood. So we have a lot of challenges that kids have coming on, and one of the challenges we have as a state is that we don't have a lot of people to help them out. At least we don't have a lot of people who are professionally designated to help kids develop these skills up here and deal with things like anxiety and depression. So this is a map of the mental health provider shortage areas for all age groups, for mental health providers to serve adults, kids, anybody. And the blue shaded areas are the counties with an official, basically mental health provider desert, the shortage area. So I believe La Crosse is not on there, but as you probably know, it's still pretty darn hard to find enough practitioners, even in places that are not officially designated as this kind of desert area. Nationally, we're 42nd in mental health workforce capacity in the nation. So I keep saying Wisconsin doesn't stand out here, Wisconsin doesn't stand out here. Here we stand out. Here we really do have a shortage of mental health providers, and that's for all age groups, and we know it's much worse for kids. So there's not a lot of places to send kids for professional help. Well, what about in the schools? Well, this is something which you may not have seen this, but I'm sure you know just in your bones, this kind of graph. So these gray lines are the number of social workers, counselors, psychologists, and nurses statewide in Wisconsin schools. The red lines are the recommended numbers of social workers, counselors, psychologists, and nurses that Wisconsin schools should have. So you would need 50% more psychologists. I think it's 9 times as many nurses to meet the need. Is that going to happen? No, that's not going to happen right away, right? So if your staff are feeling like you're stemming the tide of all of these problems, you are. I hope this is validating as well as being depressing, because you're dealing with a lot. You're dealing with a lot, which argues for thank you for being in this room, because it can't just be the nurses and school psychologists in this room, because they're never going to be able to get to everybody. So we have to have the administration that understands. We have to know that even the gym teacher, even the bus driver, even the secretary needs to be sensitized to how do we best work with kids? How do we get the best from our students, given that they're dealing with a lot and there's not a lot of people to help them work through it. I talked about the fact that we have a mental health provider shortage area. So one of the things we see from that, and this is a big concern nationwide and in the state, is that there's nowhere to send him. What can we do? Well, he's disruptive in the classroom, he's disruptive at home, I don't know what to do. Well, we can put him on drugs. Okay, put him on drugs. So we have high rates of psychotropic medication use in kids, which sometimes works. And I know people who swear by it, and I think it can make a difference in kids' lives. Problem is, we do not have good long-term studies showing what this does to kids' brains and kids' health overall. And there are side effects, and there are concerns. And so best practice would dictate, if we know that these behaviors might be kind of, did I just get louder? Whew. If we know these behaviors might be coming from something else going on, instability in a child's life, mom and dad are getting a divorce, just had to move again, third time this year, you can slap drugs on that, but best practice is there should be some conversations happening as well. And we certainly have cases of people where once the conversations happen, the drugs can fall away. What's very scary to me is that the youngest kids are the most likely to have drugs with no therapy, because who's going to see them? So in Wisconsin, we have 4,700 0 to 5-year-olds in 2014 who were on psychotropic medication. 4,700 0 to 5-year-olds on psychotropic drugs. Now, 4,700 isn't a lot statewide. There's 70,000 kids who were on psychotropic meds of all age groups, who are just on Badger Care. I don't have the private insurance information because we don't know. This is just Medicaid information. So people are trying to do what they can with the resources they have, but I think we can do better. So another thing that we see is here again, Wisconsin, yes, we do stand out here. We have very, very high rates of psychiatric hospitalizations of kids. Standout rates. So the red bar is Wisconsin's state hospital psychiatric hospitalization rates. The white one is the US average, and then I put some other Midwest states there. And I have parsed this data many different ways from many different sources because it's just so puzzling for people. And continually we stand out for having high rates of psychiatric hospitalizations. So in other states, psych hospitalizations are about the 5th reason why kids are hospitalized. In Wisconsin, it's the 1st after newborns. So newborns are the number one, kids in the hospital. You get kids out of the NICU, you get them out of being born. The reason kids are admitted to the hospital, number one reason is mental health concerns in Wisconsin. So you know that we don't have higher prevalence rates. So it's not that we're sicker starting out, but I think what we're seeing is we have fewer supports in some areas. We have a less developed mental health service system for kids. We're not getting to kids early enough. And so we see this use of deep end services, which is incredibly costly. It's also very disruptive, right? So I'm sure many of you know a lot of these emergency detentions. What does emergency detention involve? Law enforcement. So these are very potentially traumatizing experiences. I work a lot with folks at Winnebago Mental Health Institute. We have a lot of conversations with them. They say we have all these kids come here, they're back out within 24, 36 hours. Why? Because it's an issue with the family. This kid doesn't have a major mental health issue. We put them on a multivitamin while they're at Winnebago. This is a quote. We put them on, not everybody. I mean, they do treat people who need treatment, but they don't just go through like Flintstones vitamins. They have actual medications there. But they were saying a lot of these times the kids don't need psychiatric help. The family needs to be stabilized. So again, the more that can be done in the community up front, the more you're able to push these numbers down and keep these from happening. And I will give a shout out to La Crosse because I did look up your numbers, and you're 44th in the state out of 72 counties for hospitalization rates, 1 being the worst. 72 would be the best here, lowest hospitalization. So that's pretty good, and there aren't any other, I think it's the largest city. You're the lowest for the bigger cities. So there's something that's happening right in this community. In Wisconsin, we actually do have quite high youth suicide rates as well. They stand out nationally. We're between 33 and 40% higher than the national average for youth suicide rates. On the YRBS Youth Risk Behavior Survey, 1 in 7 students reported seriously considering suicide. And it's the 2nd leading cause of death for youth in Wisconsin. Again, that's not true nationally. Nationally, it's more like 3rd or 4th. So again, these are kids saying they need help, that we need to be there for them earlier in a more meaningful way. A little bit of stuff from the schools. We know that kids who have instability in their lives and kids who have mental health challenges are disciplined at a higher rate because they stand out and people try to correct that behavior, and a lot of times that looks like school discipline. So this is numbers that are reported to the feds of what are the disability categories of kids who spend 10 or more days out of the classroom. I'm sure you know these categories from your work, those of you who are in the schools. Well, these 2 bars that stand out off the charts are for kids in that EBD category, emotional behavioral, and the second one is OHI, other health impairment, which includes a lot of kids with ADHD. Okay, so this imagine how many of these kids are kids who are coming from a traumatic background or coming from an unstable background. So if we could deal with some of those issues a little bit better in the classroom, in other areas, could we bring those numbers down a bit? Because the research shows getting people out of the classroom is not helpful to them. And I hope people know this research as well. There's research that recently came out that shows getting kids out of the classroom is actually not helpful to the other kids. Are you all familiar with that study? So this is what they're finding, that when you expel children, the rest of the classroom's grades go down. There's a chill effect. So you think, well, we have to get him out of the classroom because it's not fair to other kids, they can't concentrate. But actually, the other kids start to do worse after Johnny's removed. So we need other ways of approaching school discipline that work better for kids. Rethinking social sanctions, school to prison pipeline kinds of stuff. We see a lot of youth detentions happening. And the thing is, when you look at kids who go into the JJ system, 70% of those cases have nothing to do with hurting a person. They are nonviolent. They are property offenses. They are public order offenses. They are other. And then the Department of Corrections has done some great forward-thinking work. They're starting to look at the kids in their system, and they're asking them, tell us your ACE score, tell us your traumas. 98% of the kids there said yes, that they had ACEs. And I would venture to guess that if we expanded the ACEs questionnaire and said, okay, so you didn't have sexual abuse. Were you homeless ever? Well, yeah, I was homeless. Did you have a sibling who died when you were young? Well, yeah, that. Did you have neighborhood violence? Well, yeah, that. I would venture to guess that you would have probably close to 100%. But we know 98% have one or more ACE. And most of them have 3 or more ACEs. And so the thing that stood out the most to me over this past year or so when I've been looking at Wisconsin data is, on most measures we don't stand out. We stand out on hospitalizations, we stand out on suicide. We really stand out on these disparities. And this is what people are hitting home on today. And it's great that we're addressing it because it really is a problem in Wisconsin. So this is suicide risk, and this again is YRBS data. And I put the top category of youth saying that they are experiencing, that they attempted suicide in the last year is LGBT or sexual minority youth. They are at high risk in Wisconsin, they are at high risk nationally. But they're not at higher risk in Wisconsin than they are in other places. Black youth are at much higher risk in Wisconsin than they are at other places. It's scary to be a youth of color in Wisconsin because it's not a comfortable place. That's what the kids are telling us. That's what they say in their survey. We can see again and again. So Wisconsin's black youth suicide attempt rate is 82% higher than the national average. And LGBT, Hispanic, and Black are at the highest risk overall. And that just keeps going further and further. So highest risk of attempting, highest risk of attempting and being hospitalized for it. And one of the things we're seeing nationally is that youth suicide rate, I'm sure you all know, is going down in age. So I recently saw some data showing that Black youth of color ages like 10 to 13 are at a much higher risk of suicide than we previously knew. So we're talking about younger and younger kids. School discipline, we talked about this. We see not just the disparities based on disability status, but severe and pronounced disparities based on race and ethnicity. And again, the national studies will show, that the same behavior from a white student and a black student oftentimes gets treated in different ways. And what gets seen as disrespectful and what gets seen as disrespectful enough to send somebody out, that bar, that threshold is a lot lower for youth of color. And so that's an important thing for us to think about as we're moving forward. So 21% of black students were suspended in 2013. So that's like on the order of the number of kids who have mental health issues, 1 in 5. 1 in 5 black children were suspended in 2015, which is more than 9 times the rate of white students. American Indian students were more than 3 times the rate of white students, and Hispanic Latino students were twice as likely as white students. And the other thing we know from this data is oftentimes the same kids with the same behaviors are treated in different systems. So what is a behavior problem oftentimes in a student of color can be more often seen as a mental health issue for a white student. And so again, it's expanding our lens and saying, let's look at this as a mental health issue or a trauma issue or an instability issue for all kids. We see these disparities in a very marked way in out-of-home placement. So this is CPS, this is kids in foster care. Very pronounced. And this one, again, I think Wisconsin's second to worst in the nation in terms of kids of color being placed outside the home. Here it's highest for American Indian children. Despite the fact that there's federal legislation to work on this, it's still very high. Whoops. Oh, I cut a lot of slides to try to be, try to go ahead. So what I want to show here is you've been describing the problem. I'm adding a little bit more to describing the problem so that you can have some tools to take back when you're working with folks. But what's exciting is we're starting to talk about these problems. We're starting to talk about them at the local level. We're starting to talk about them at the state level. And I think having these conversations which are engaged, which are informed by data, and which are reflective can make a huge difference in starting to take a step forward. At the state level, we're trying to put together work groups to deal with these issues. I will tell you, we're bringing these slides into state conversations. They are not comfortable. People do not like to be at these tables. But people are showing up. And that's what we need to do, is just keep showing up and learning from one another as we're trying to move forward on this. Thank you.